Well, thank you for coming, bringing your lunch with you as well. Why not? It's me again, folks. Yes, you've seen me before. But I'm really, really pleased to be able to interview Dr. Mark Tyndall, who I hope you all heard yesterday, giving the inaugural keynote. But he's written this book, and it's called Vaping, Behind the Smoke and Fears. Available on Amazon. And the man has brought a few copies with him, so don't all rush at the end, and I'm sure he'll sign it for you. So let's just kind of, I mean, some of this I think you sort of covered a bit, you know, when you were talking about your background. But just for people who, because it was a long time ago, and there was a party last night, so people might have forgotten by now. Just a little bit of background on you and how you came to think, I need to write a book about this. How did it all begin?
Okay, well, I had a long story of harm reduction, but mostly focused on HIV prevention. And it came, I mean, I talk about it in the book. When I first heard about vaping, I was working with a large cohort of people who used drugs. Many had HIV, and the role of the study was just to look at outcomes and natural history of HIV among people who are injecting drugs. And I realized when we were looking at outcomes that most people were getting sick or actually dying of smoking-related diseases. And the people that I had a community advisory group with me, and when I established that group, within a few months I lost 3 out of 8 people to smoking-related diseases with COPD, lung cancer. So it occurred to me, this is crazy. I'm following all these people, making sure they're on their HIV medication. They're all smoking, and they're getting sick from that. And vaping offered them, we should get you guys an alternative. So that's how I got into it.
And how far back are we talking?
So that was 2012.
2012.
2012,
and
okay. I most of my career I've worked in Vancouver, but I was in Ottawa for about 5 years, and it was in Ottawa, and I wrote an op-ed to the Ottawa Citizen in 2012, and it got a lot of good feedback. It was just kind of obvious to me that we have a really safer way to get people off cigarettes, and there was quite a good feedback from that. And if you told me, like, I guess it's been 13 years later, that we'd be no further ahead, that I would have thought this is crazy,
Right. So, so you wrote. Is this your first book?
It's my first book, yeah.
Right.
So I've written. I mean, I have an academic background, so I was pushed to write academic publications. So I spent a lot of my time doing that, but I never wrote a book, and I wanted to. It kind of like it has a bit of a memoir feel to it too, so I tried to put like my own stories in it, so it's not just a technical book or a medical book. So I tried to make it a bit more accessible and just about my journey in medicine.
Well, I've read it, and you managed to achieve that, which not a lot of academics can do. They can't really write in a popular style. It's normally 2 lines of text and 27 footnotes. so you've done really well on that. I mean, presumably you had to fit the writing of this in between all your clerical
your
clinical work? No?
Maybe you set me up for that question, but no, I had 2 years of living in Bali, Indonesia, and that's when I wrote it. So I had decided I just needed a break, and I left my job I was head of the BC Center for Disease Control, and when that term ended, I decided that I needed a break, and went to Bali. So my wife is her family's from Indonesia.
Oh, okay.
At that time, my son was 9, and there was a place called the Green School in Indonesia, kind of an environmental outside school, and so we thought it'd be cool if he got to go there, and. So we sold the house and packed up our stuff in a locker and headed off to Valley, and we ended up being there for 2 years.
Right. You talked about, your frontline work with people with drug problems, with HIV, and you sort of came to a realization that, people were dying needlessly from tobacco-related diseases because everyone smoked. But in that sort of frontline clinical atmosphere, I mean, did your colleagues get it? The people who were seeing people with drugs problems and AIDS, did they understand what you were going on about?
Not really, and I don't think they do still.
Right.
I think that the approach to people who are using what we would call harder drugs, there's quite general acceptance of a harm reduction approach to things, that there's a realization that people aren't going to quit right away, and that we need to, prevent overdose deaths and HIV and these kind of critical things. Smoking, even though it's addictive to people, is really looked upon as a nuisance type thing, and that people should just quit. I think my colleagues feel that, they have some empathy to somebody who's, using heroin or cocaine every day. But if they smoke every day, it should be good enough just to tell them, well, just quit smoking, and it's not a big deal. And so, people really differentiate a harm reduction approach to harder drugs, and then nicotine is kind of off on the side as a kind of trivial nuisance thing, which clearly it isn't.
Right. It's interesting because there's a very relevant session tomorrow morning which talks about who else should be in the room when we're discussing tobacco harm reduction. And quite clearly, people who ought to be in the room are people who are working in drug services and HIV services. Why do you think... So you think the reason they're not there, and we know that we found it very difficult to engage with those people and those organisations. Sometimes I think, well, there's always the elephant in the room, which is the industry, isn't there? In kind of, you're trying to promote products that come from, I don't know if that's part of the scenario, but what you're saying is something I hadn't thought of, is that you've got people who are steeped in clinical addiction work, not actually seeing cigarettes as particularly, what's the word? Implicated in the problems that their clients have.
Well, I think until vaping we had alternatives, it was pretty unlikely people were going to stop smoking. And it's actually a form of harm reduction as far as using other drugs. Most people who are, using street drugs every day, the first thing they'll use in the morning is a cigarette, and they might use several cigarettes before they go out and search what other drugs they want. Yeah. And if they didn't have that cigarette, they'd be pushed to get out probably an hour earlier. So in some ways, it was a very helpful thing. So I didn't think it was possible that many people would stop using nicotine, but if they could use nicotine in a much safer way, then that totally makes sense.
And presumably you must have had conversations with clients about their smoking or what they might do about it, or did they say to you, well, Dr. Tyndall, I'm kind of waking up and coughing my guts out in the morning, and I'm spitting out bile and blood, and I don't like this. Is there anything I can do about it? I mean, do those conversations ever really happen or not? Or was it just the way things are?
I think some of those conversations happen. I think most of the people that I got to transition over, it was my idea that, you probably should think about that. But it made sense to a lot of people. I think if you're sitting in front of somebody who's, really entrenched in the drugs at that particular time, you could make a case that, well, smoking's not your biggest issue right now. There's a lot of things you need to work on. However, and you kind of make an assumption that they don't really care. But people really do care. They, you know, they're doing things that we look at as kind of very harmful to them, but it's not because they don't want to be healthy. And so I'm always impressed with when I talk to somebody who's, you know, not doing well as far as their addiction goes, about feeling better off cigarettes. They're quite engaged with it. So a lot of people think, oh, yeah, that's a good idea. I'd like to, I cough way too much and I can't walk as much as I used to. And yeah, that seems like a good idea. So.
Right. And just a quick overview, this is not on the sheet of paper, but I'm sure you know, just about the ease of access of products in Canada. You know, if you're encouraging people to switch, okay, so they've got to get money to buy drugs, but is there money to
No,
buy
I think
vapes?
that's a huge problem. So when I started in Ottawa, I got some donations, so I got people to start that way. And it was, you could make a case that vaping is actually cheaper in the long run, but people don't really see that when they have to put out the initial 30 or 40 bucks to get started. And so I think if we're serious about, you know, helping a lot of people transition, then it makes total sense to me that we offer people who can't afford it vaping products. And so I did manage to get some people started, and the people that have continued have found ways to get their own, because I couldn't continue it. But that is an issue. And certainly, if you're buying bags of cigarettes and bags of tobacco and rolling your own, or buying bootleg cigarettes for $2 or $3 a package on the street, that's vaping. You know, buying vaping products is not cheaper. So it's. I think that is an issue for sure.
And I mean, in Canada, you've got the federal government. Presumably, you've got individual territories as well. Does everyone have a different take on this from a legal point of view, or is it pretty uniform in terms of what you can buy and what you can't, and what flavors and all of that?
Well, it's in a state of flux. Each province tries to come up with their own restrictions, and there are provinces who have flavor bans and things. But generally, there's vape shops across Canada, so people can get it. And there's a lot of illegal sources that people can get. Of course.
Listening to your keynote yesterday, you talked a lot about the nature of medical groupthink, and why that's like that. And of course, the medical people that you really want to address are the people who deal with those people with respiratory diseases and all the things that we've been talking about. So can we talk a little bit about the groupthink that I think you write about it in the book as well.
Yeah, obviously writing the book, I talk to a lot of people, and I'm always amazed how little people know about it. The medical, either physicians or nurses or healthcare workers, are pretty much clueless about safer nicotine products. They haven't really bothered. The tobacco control idea is in the public health unit somewhere in the province, and they're the ones who, put up the no smoking signs, and they're the ones who are supposed to be, navigating this. And most healthcare professionals, even though they might be faced with somebody who's smoking and know that they should stop smoking, in a policy perspective, don't really want to get involved. And if they've been told by, the public health institutions, whether CDC or what they've read on the websites or whatever, that we don't really know how safe vaping is, and it's not, it's probably not worth switching. I think most of my colleagues, most physicians haven't really gone beyond that. They just, okay, yeah, I guess it's not worth it. And so, very few physicians right now in Canada are encouraging their people who smoke to switch to a safer product. It's just, they just don't seem to understand.
So they almost seem to be, well, two things really. One, they almost seem to be accepting that the person sitting in front of them is just going to carry on
Yeah.
smoking.
Yeah, I guess a lot of people have had very little success. So they've had, they've had a lot of success getting people on patches, and 5 to 8% of them are successful. And I guess you just figure it's not going to happen.
Right.
I mean, I use in the book, if we really look at vaping as a treatment for cigarette smoking, we would treat it entirely different. So if you came to me with very high blood pressure, and I said to you, I'm going to give you something that I want you to take, and you come back a month later and you say that, and I check your blood pressure exactly the same, and I said, I know the pill that I just gave you is only effective in 5% of the cases anyway, so I didn't really expect that it would work for you very well.
Right.
Like that, you would never do that, right?
No.
Or if you told people, you knew they were going to have a stroke from their high blood pressure, and you just watched them, and then and you never offered them anything, and they had a stroke. I mean, that would be malpractice.
Yeah.
So we have somebody who's smoking, and they're getting sicker and going to die from it, and you've offered them nothing. I mean, I think should be malpractice. But we look up on it, well, it's what people do. They don't quit, so we'll just watch it.
That sounds like mass litigation waiting in the wings.
Yeah, and imagine if you had, like I use this example in the book, if you had diabetes and you were being followed by your family doctor, and they just watched your sugar really high, and your leg turned black, and you lost your leg, and you'd go back to the doctor and say, well, and he'd go, well, yeah, I knew that was going to happen because your sugar's so high for so long. And he didn't offer you anything. Like, you'd go, whoa, what? What do you mean? You knew I was going to lose my leg, and you didn't offer me anything when you could have given me something? And so I think that's analogous to not offering people safer nicotine.
But is it the fact also then that you spoke earlier about, your colleagues thinking, well, smoking is just a nuisance, right? So they're not thinking it's a problem. And maybe the client isn't thinking about it's a problem. It's something, I've got into the ritual, like you were saying, first thing in the morning is what I do. I light a cigarette. I need something to do with my hands. Yep. I can share cigarettes with a friend. There's a whole kind of ritual, isn't there? It's beyond the nicotine, really. And it's all part of that. So maybe nobody's really that concerned until you can't breathe properly, you can't walk up the stairs.
Or you rush to hospital with your heart attack,
Yeah.
And then it's kind of interesting too that some of the most loudest anti-vape people are cardiologists and respirologists and oncologists who really only see the worst part of smoking, and they usually have contact with that patient when they present with some acute smoking-related problem.
Right.
And they don't really understand the 30 years that led up to that event, because they've not known the person, and the maybe a family doctor who's followed people a long time don't really see the end point of their smoking. So,
but from a clinical point of view, is it still not too late in terms of somebody coming into hospital and they're in ER or A&E, whatever you call it in Canada, and it's like, phew, well, you had a close call there. Yeah. You really need to think about, your cigarettes.
I've had a lot of experience in that, working in hospitals, and it's amazing the people's response. So it's really one of two things: either I knew this could have happened to me and it's too late, now look what happened to me, and they kind of accept their fate, or it's a wake-up call. This is, I really never will smoke again, and people don't smoke again.
Right.
But there's a few longitudinal studies, but people who, a large observational study of thousands of people who entered hospital in a non-smoking environment and didn't smoke for like a week or 2 weeks during their hospitalization, and were committed to stopping smoking. When they're followed up, 6 months later, 10% had continued to stop. So you would think a wake-up call would be a real jolt to people, but it still, the majority of people will continue to smoke. Now, one of the other things that's really, I think, important for this transition to vaping is studies that looked at how resilient smokers are. And so you can smoke for 20 years, and if you stop, your life expectancy is about the same, you know? And it does deteriorate after some time, but I think the work by Prabhat and these long-term cohort studies of people who have quit smoking, it's really never too late to stop. Right. And you will benefit. Obviously, the earlier you stop, the more benefit you get. Sure. But it's quite resilient and quite forgiving. And I was just at the session around flavors and toxicology and things. And so the tiny bit of toxic material that you might be getting compared to smoking, for instance, if you can have this, you know, blitz of toxins from tobacco for like 20 years, and you can recover, vaping, the little bit of exposure you get, it doesn't make any sense that it's going to really cause any problems for you, because your lungs are like really a resilient organ for the most part. You can really punish them, and so it's really never too late for people to switch to a safer That's product.
Right. We're coming to an end. There's so many questions that I could ask you, but who do you hope to reach with the book? How are people going to find out about it?
Well, you're going to spread the news.
We're going to spread the word.
These are my disciples.
We'll tell a few people.
Yeah, so I don't. This first time I've written a book. I mean, I self-published it. Yeah. So I don't have anybody out there. So it's on Amazon. I'm doing a few podcasts and things. Right. So I hope that it spreads. I mean, I think hopefully it's got a relatively wide audience. I mean, I hope it's a wake-up call for my public health colleagues and physicians to kind of dig into the information. Yeah. Most relevant, I think, to people who smoke, that they're doing the right thing by switching, because there's just so much misinformation. Even many people who have transitioned to vaping still in the back of their mind have doubts whether this has really been worth it or not. And so you really need to emphasize, yeah, this is the right thing to do. And parents even, I think, who are inundated with so much misinformation about what's happening to their kids, I think can also get some information. So hopefully it's got kind of a wide readership. Right.
You need to be sending out review copies as well, I suspect.
Yeah.
Hard copy, review copies, to all the right places. Some of the, the mainstream media as well, I think this is a terrible thing to say, but well, I don't know if it's terrible or not, but you're untainted from that point of view. Nobody can turn around to you and say, well, he would say that, wouldn't he? Because of any connections, however tangential, with industry. And this is where a lot of people fall foul of cancel culture and all the rest of it. You've had a little bit of that, haven't you? A little bit of cancel culture.
Yeah.
Tell us about that.
Well, I was I talk about it in the book. I was asked to have a debate with Stanton Glantz at a Canadian public health conference, and we were going to be the last debate of the conference. It was the annual public health conference in Canada, and I had a meeting with him on phone, and I knew who Stanton Glantz was, but I never had met him, and he was the most arrogant guy on the phone. I was just like, after the call, I thought this was why did I agree to do that, But I did think of some funny things to say, so I thought at least I'll make it entertaining for the audience, But then I got a call 2 days before that the organizing committee had decided that I would not be appropriate to do it because of my views on harm reduction, and that I didn't have a long history in tobacco control, so I wouldn't be the right person. And at that time, Stanton was also up against all these legal battles he was having at the university, so he got pulled also. So the whole debate was canceled. So, but the main reason that I was not, that I was disinvited was because of my views on, and I wasn't representative of what public
they
health.
must have known this before they invited you, did they?
Well, I think the guy who invited me wanted that kind of controversy, but once it got out that he had invited me, I think the rest of the committee ganged up on him and told him that that was a mistake.
Thank you. We've got a couple of minutes left. I don't know if there's any questions from out there. I'm blinded by the light here, to quote Bruce Springsteen, but I can't see if there's anybody out there who's got a question. If you have, shout.
Maria?
Well, I just want to say thank you on behalf of a lot of people, but especially in Canada. Oh, sure.
Go on, take this. I can shout.
Thank you. I can shout too.
You can shout. Sure you can.
Dr. Tyndall, I just want to say thank you to a lot of people, not only in Canada, because you've done an incredible job of ensuring that the conversation doesn't stick to just kids. It sticks to harm reduction. And I know that that is a bit of a risk that you took to get the truth out there. Not everyone makes those risks. So thank you. And this book is absolutely incredible. And, you know, I hope everybody buys one and then buy a copy for your library. That's my thing right now. Buy a copy for your library if you can, because this should be accessible. It's easy to read and accessible to everyone that wants to be part of this debate and understand the other side. So thank you.
Great, thanks, Maria.
Thank you. And thank you all for taking up your lunchtime to come and hear the... Oh, you got another question? Where's this?
I wanted to ask.
Ah.
You're Canadian. You have healthcare as a human right. We do not in the United States. We have 30 million people who are uninsured, and that's probably going to get worse because of our president. So people in the United States don't have access to healthcare providers like countries that have national healthcare systems. So I'm wondering if you could comment on how that, I mean, it hurts us because people can't see doctors, nurse practitioners, and there's also a massive amount of distrust among patients in the United States for the medical system. I know this is a huge question, but I'm putting it out there because in Canada, you don't have that problem. In England and all these. So do you have any advice for the US, given our utterly dysfunctional healthcare system?
You've got about 10 seconds to answer that one.
I think any success we've had with alternative nicotine products have really been from groups like Maria, and so it really hasn't been driven by healthcare providers at all, and it's really kind of grassroots and people in vaping shops and things that have really pushed this along. It's hopeful that healthcare workers will get on board at some point in time, but I don't think that's a real disadvantage to Americans because we're not in a situation where it's medically suggested that people transition. They should quit. So,
Okay. Thank you very much
okay, thank
for
you.
your questions.
So
and
I do have some books.
yeah,
So I
have some books. Form an orderly queue.
I just brought about 6 or 8 books. If anybody's interested in getting them, I just bought them off Amazon myself. So if you can come up with $20, that would be useful, and I'd be happy to sign it.
Okay, thank you, Mark. Round of applause for our author, please.